Good evening, everyone, and thank you for joining us today. Welcome to today's webinar, hosted specially for our community of primary care physicians and GPs. We are glad to have you with us for what promises to be an insightful and clinically valuable session. It is my great pleasure to introduce our guest speaker this evening, an esteemed specialist in the field of obstetrics and gynecology, Professor Mohamed Rishard, a board-certified consultant currently affiliated with the De Souza Maternity Hospital in Colombo. I am sure that many of you either know him personally or have at least heard of him. I've had the privilege of knowing him for many years, and he's the one who in fact delivered my daughter. It is my great honor to now share a brief overview of his impressive professional journey for the benefit of those in the audience who may not yet be familiar with his background. He currently serves as a professor and senior lecturer in the Department of Obstetrics and Gynecology at the Faculty of Medicine, the University of Colombo. His medical journey began with the completion of his undergraduate degree in medicine in the year 2005 from the Faculty of Medicine at the University of Kelaniya. He pursued his postgraduate training with dedication and excellence, obtaining his MD in Obstetrics and Gynecology in 2012 from the Postgraduate Institute of Medicine, University of Colombo. His commitment to furthering his expertise led him to the United Kingdom, where he undertook foreign specialist training at the Whittington Hospital in London from 2013 to 2015. He earned a postgraduate certificate in medical education from the University of Dundee in 2016 and went on to receive both a Bachelor in Endoscopy and a Diploma in Endoscopy from the European Society of Gynecological Endoscopy in 2017. He is a prolific contributor to academic literature, having authored and co-authored numerous articles, many of which have been published in both international and local journals. Over the years, he has also been recognized for numerous honors and awards, a testament to his dedication, expertise, and impact in the field. There's way too many to mention. It's about 17 pages long. So in the interest of time, I will highlight just a few of these. The Professor Sir Sabaratnam Arulkumaran SLCOG Young Gynecology Award in 2022. The Shan S. Ratnam Young Gynecological Award in 2013, awarded by the Asia-Oceania Federation of Obstetrics and Gynecology, and the Bronze Medal at the Geneva Inventions in 2014 for the invention of improved condom catheter use to treat atonic postpartum hemorrhage. Today, he'll be speaking to us about practical approach to perimenopause and menopause, offering practical insights and guidance tailored for the primary care setting. Before we begin, just a few housekeeping notes. This session is being recorded and the recordings will be made available to all registrants after the webinar. All attendees are currently on mute to minimize background noise. We will have a Q&A session where you can voice out your questions or use the Q&A box at the bottom of your screen, and we'll try and see how much we can try and accommodate as much as we can at the end of the session. If you do experience any technical issues, free to message us in the chat group, and our supporting staff will assist you. So please join me in giving a warm virtual welcome to Professor Mohamed Rishard. Rishard, over to you.
Yeah. Can you see the slides? I can't see the slides.
We can see the screen. We can see the first screen. Rishard.
First screen, right? You can see that,
yeah,
right? Okay.
I can see it. Yeah.
So, yeah.
Can you move?
Yeah, fine. Thank you.
Yeah. Okay.
Right.
Fine.
We can see that.
All right.
So, thank you for your kind introduction, Dr. Sabit. Thank you. So, thank you for inviting me to deliver this talk. So we'll start without without an introduction. We can straight away. Yeah, let's see. This is actually a woman from Mayan community, a community that lives in Mexico or South American region. Actually, these women they are the community that has minimal or that experiences minimum symptoms of menopausal symptoms. Okay, it is attributed to their lifestyle, their food habits, and some other things as well. But they are well known to have have minimal symptoms of postmenopause or menopausal symptoms. until recently, Japanese were actually not able to describe what hot flashes are actually. In Japanese, the language also don't kind of have a proper language to its, describe hot flashes or hot flushes. That is a commonest symptom in other women, postmenopausal women. And again, Maori, a community that lived, or ancient community that lives in New Zealand, they are actually, the community leaders are supposed to be women from, or menopausal women. Okay, so they think they attribute, or they assume they are the women with wisdom. So throughout the world, menopausal women are considered to be women with wisdom, and but unfortunately, some other a lot of women with the rising aging population, billions of women are actually suffering because of menopausal and postmenopausal and perimenopausal symptoms, and their quality of life has become poor because of these symptoms. Women's health status when they enter into perimenopausal period actually determines the perimenopausal symptoms, and the life and the quality of life after menopause is actually determined by prior health and reproductive history and environmental factors. Okay, and also cysty, and so prevention of this, actually preventive measures and good lifestyle plays an important role in promotion of healthy aging and quality of life. So recently, actually, I was invited to write a chapter on premature ovarian insufficiency in a book on menopause. So a lot of literature, a lot of input is coming into kind of scientific literature because a lot of research is ongoing. So with that, I am going to share a little bit of, practical tips actually with regard to this perimenopause and menopausal age. And let's have a quick discussion on this actually. So menopause is actually defined as, we define when the period is, when with the decline of follicular activity, we usually diagnose after 12 months of cessation of menstruation, or when they are amenorrheic for more than 12 months, we define, okay, you have reached menopause. But most of the women, this won't happen all of a sudden. It takes through various phases, like, at the age of 45 onwards, or from the age of 45 onwards, they start to experience, this age is called perimenopausal age. Okay, so perimenopausal age, slowly that will merge, or that will reach to the age of menopause. And initially they will have shorter cycles, and then cycles will become longer, and these cycles are called anovulatory cycles, and they will start to feel symptoms of menopause. And at the age of roughly around 50 to 55 years of age, they will experience, or they will become amenorrheic. Usually the mean age is in Sri Lanka is about 51. So there is a phase called premenopausal phase, perimenopausal phase, and then menopause and postmenopausal phase. This is these are some phases that women go through. So common symptoms that we hear from women at this age, or perimenopausal or menopausal age women face, is hot flashes or night sweats. And urogenital symptoms such as vaginal dryness and reduced libido, sleep disturbances, and aches and pains, low mood, anxiety, irritability, sexual dysfunction, and they become little dementic, and they become irritable, loss of sleep. and urogenital symptoms. All these actually not only affect them, and it affects the people around them as well, their children, their husband, and in the workplace. So if you look at this picture, this as a recap of what we have learned during our medical school. So it involves CNS, it involves skin, mucosal and hair, weight and metabolic changes, sexual dysfunction, urogenital system involvement. So if you look at this, in my practice, when we see patients in clinics, we see all kind of patients. Some women come with vasomotor symptoms. They come and say, "Dahadiya dano, doctor, inda bær, after sitala dano, dahadiya dano, sitala dano." They describe that way. And they say they can't sleep properly. They are depressed and they are anxious and they experience headaches and migraines and cognitive changes. They become forgetful and they forget a lot of things. And the husbands and the family members come and complain. So these are central nervous system involvement. And skin loss of elasticity and dryness and loss of hair and wrinkling, those are some of the skin and mucosal changes. Urogenital changes are again a common symptom. They complain of difficult sexual intercourse, itching and dysuria and dyspareunia during sex. And some of the women, they come and say, "Mama mahatuna, බඩ දාලා තියෙන එකපාරට බඩ දැම්මා ડોක්ටර්. හොඳට හිටියා එකපාරට ලොකු බඩක් ආවා. මට ගෙඩියක්ද කියලා බලලා කියන්න." So when we look at it, it's full of fat tissue and it's adiposity. It is because of the adiposity change, redistribution of the fat tissues in the tummy. They get a little bit of truncal obesity, which we are going to discuss in the next slides. So we should understand when they come to us, we should be able to explain to them, we should be able to listen to them as the primary clinicians, clinicians in the primary care setting. You should be able to listen to them and understand and attribute it to their perimenopausal and menopausal changes and either treat them or advise them or direct them to some special care settings. So actually, you should know that, severity of the symptoms, if they are coming with severe symptoms of sleep disorders, it is also linked with severe, cardiovascular involvement later in life, and it affects their cognitive functions as well. So if they are coming with severe symptoms, you should be able to identify and address it then and there. So if you look at this, again, although it looks this slide is kind of a complicated one, it is not complicated. It just tries, these symptoms, it tries to explain the symptoms here, vasomotor symptoms. You should know, at least patients will ask you, "Ai mata mehema wenne, ai doctor me daadiya daanne." If you explain, you can explain it in simple terms. Or periods නැවතිලා ඔයාගේ estrogen අඩු වෙච්ච හින්දා හොම වෙනවා. In some way, you should be able to say it narrows the thermoregulatory set point. You don't have to explain in that way, but you should know what happens to them. It narrows down there is a thermoregulatory system in the hypothalamus that it's a broad area. There is a kind of large window, but it becomes a narrow window so that they get kind of heat loss and they sweat, they feel heat, and as later they get a cold sensation also. So that is vasomotor instability, but actually it is not very much understood. Okay, CNS symptoms, that is a commonest symptom and that affects them significantly. Then there comes the second one, urogenital mucosal involvement. Because of the lacking of the estrogen, that vaginal tissue become, initially it is elastic and there is a kind of rugae pattern that goes away and reduce collagen synthesis, and vaginal wall become weak and it can't, they get urinary symptoms, urinary stress incontinence and urinary mucosal prolapse, or we call it vaginal prolapse. And also that skin, when the estrogen is lacking, they get they are prone to get infections. So they frequently come with either vaginal discharge, yellowish, sometimes pinkish vaginal discharge, and irritation. And when they have sexual intercourse, it irritates them. So that is a common complaint. And sometimes they may not come out with this. The husbands will come and tell you. And then cardiovascular involvement, we know that LDL level will go up because LDL, this lipid profile is maintained largely depend on estrogen as well. So when the estrogen is lacking, LDL level will go up, HDL will go down, and there is a risk of cardiovascular, to the cardiovascular system. And again, bones, osteoclast activity will go down, and osteoblast. There is a balance between osteoclast and osteoblast, and that disruption leads to less bone density, and they will get osteoporosis eventually. These are the common major problems. So hot flashes, as I told before, it's the most prevalent symptoms. They come with hot flashes that can start at the age of 45, and that can last many years also, but usually 1 to 2 years. Most of the women, lucky ones, will have about hot flashes for up to at least 6 months. So usually it starts in the chest, and it lasts to 1 to 5 minutes, and it occurs in the night, triggered by stress and environmental changes and spicy food in some patients. And they also have spells of cold feeling as well. So it is actually hot flashes and සීතල දානවා, heat එනවා, සීතල දානවා, දාඩිය දානවා. They will explain it in various ways, and actually don't tell that most of the doctors, when they explain it, you should actually listen to them as well, and you should listen to them and understand and how it has affected the quality of life, and what remedies they do, home remedies, and they will describe. And please try to listen to them and understand and note it down as well. And it is often accompanied by anxiety and palpitations. And as I said, reflex cooling is there in the, that heat waves, when dissipates, it causes chills after the flash. So they are scared. They, although they know, some of the women are not aware of this, and they get upset, they become depressed, and they lose sleep as well. So you should be able to explain this, and there are treatment options, there are remedies, and there are lots of options available. So you should kind of explain and educate them as well. So that is about hot flashes. The other thing is bone changes. As I said before, osteoclast and osteoblastic activity, it is affected, and usually this bone changes, this can be tackled by good physical activity and lifestyle changes, and also calcium intake. If they have adequate calcium intake in the food along with vitamin D, they don't face much bone marrow density kind of issues, and they don't face osteoporotic fractures. So it depends on the calcium intake and vitamin D intake, depends on the dose, good adherence, and good lifestyle as well. So this is the this is how this picture illustrates how they when the bone osteoporotic changes, they become slightly they shorten because of the osteoporotic changes. Their height, initially they are tall, and slowly their height, and they become kind of this shape. And yeah, so we know that bone density is peak at the age of 40 to 45, and slowly it lowers down. So you should, whenever you see kind of when you meet or when you see women at their reproductive age, you should be able to advise them on good lifestyles, and to, as a preventive measure, you can good weight bearing exercises, maintain the body weight, and calcium and vitamin D intake will reduce or minimize osteoporotic fractures in menopausal age. So we looked at hot flashes, we looked at osteoporotic changes and some osteoporotic changes that occur in the postmenopausal age, and aches and pains. That is again a common problem. Osteoarthritis, it is common. It is because of the lubrication, lack of lubrication in the joints lead to increased wear and tear. This is basically lack of estrogen causes. Hormonal fluctuations lead to kind of changes in the joints and tissues, and those tissues are prone to inflammation and pain. So they get like various aches and pains and joint related issues. Muscle weakness and is again a common problem. And also, along with that, weight gain. Women at the age of menopause, they tend to gain weight. This puts additional stress on the joints, especially knees and hips. So look at this. We get lots of, we encounter this problem. Women have a different shape or figure that slowly changes into a different one. So initially, in Western world, they say an apple-shaped body becomes a pear-shaped body. So that is because of the fat redistribution in this age. So this can't be kind of prevented, but this can be minimized. This can be with good lifestyle measures, good exercise, because this is actually, we'll discuss again, this is because of the estrogen or androgen excess in the body. So now we'll look at the cardiovascular involvement. Estrogen is cardioprotective. It is a well-known fact. And it increases HDL levels and reduces the LDL level. That fact you should know. So women at postmenopausal age at risk of cardiovascular diseases, when they have additional risk factors, that risk is increased. Then urogenital tract, we have told, decreased vascularity and irritation leads to, epithelial changes, lead to irritation, burning, itching. And subsequently, they get atrophic vaginitis and dyspareunia, trauma, and bleeding after sex is very common. Sometimes, they may come to you, they may come with postmenopausal bleeding. Sometimes they may come and tell you, I have a vaginal discharge, which is a kind of blood stain. Then you should understand 90% of the women, when they come like this, that is because of the atrophic vaginitis. Skin in the vaginal tissues peels off and they come with this discharge. They present with this discharge. Urogenital changes are one of the commonest symptoms that perimenopausal and menopausal women face. And again, pH changes into alkaline state and susceptible to get infections. More than that, at this age, because of the connective tissue and ligament of the structures become weak, previously if they have had multiple pregnancies, that becomes an additional burden. And later, uterine prolapse, vaginal tissues can come through the vagina, anterior vaginal wall and posterior vaginal wall. That can prolapse, leading to either cystocele or uterovaginal prolapses. So at this age, small prolapse, a cystocele or small rectocele is a common thing. Usually you don't have to do anything. Okay, so this is actually, you see a picture of a small prolapsed bladder. If they don't have symptoms, just because they feel it, when they go to washroom, doesn't warrant any surgical management. Okay, if they have repeated urine problems or urine incontinence or stress incontinence or less emptying or incomplete emptying of the bladder, or if they are distressed, then you should refer to a gynecologist for surgical management. Other than that, we wouldn't do anything. So at this age, this is a common occurrence or common symptom. In this picture, this is the cervix actually. You're seeing a cervix with these spots. This is not a cancer or anything. This is atrophic vaginitis. When the skin peels off, that becomes reddish spots like this. Okay, this is how we diagnose atrophic vaginitis. So we had a look at various, broadly the symptoms or systems involvement. I told you about bone involvement, cardiovascular involvement, urogenital involvement, and hot flashes. And also cognitive functions like dementia, those are the other problems. So these are the main issues that we have to address, or when we are worried at this age. Okay, when they reach menopause, so primarily, this is actually, we diagnose based on the symptoms only. We don't have to do any blood test. Some people do kind of blood tests to diagnose, estradiol level and FSH levels. You don't have to do it routinely. When they reach menopause after 45 years, unless when there is a kind of, if there is a bizarre pattern, if there is any doubt, if the woman wants to know, then you can do it, but we don't have to do it. So doing FSH is actually reserved for women less than 45, that is to die, or at less than 40, to diagnose premature ovarian failure or premature ovarian insufficiency. So you don't necessarily have to do FSH. It is basically a clinical diagnosis based on the symptoms and amenorrhea for more than 12 months. Then you diagnose menopause. So when they come to you initially at primary care, you have to take medical history, previous menstrual history, surgical history, contraceptive. Sometimes when they are on Depo-Provera for many months, they become amenorrheic. In that case, you can't diagnose as menopause. Okay. So sometimes they are on Jadel implant and they come and tell you, oh, mama Jadel ekak dala tiyena period. So unless you ask, unless you kind of question, they would not tell this also. Okay. So that is one thing. And family history, especially about cardiovascular diseases, osteoporotic conditions, and cancers, lifestyle, habits, physical activities, all these things should be should be considered, or you should take this into consideration when you see a woman at this age. Before kind of anything, you should take a quick history. And as I'm not going to waste time on this, you all do this, but you have to look at the when the medical history. And in the medical history, ask about, we often forget about DVT and history of pulmonary embolism and other gynecological malignancies. And of course, breast examination is mandatory, because we all know that estrogen or whatever hormone replacement, if you are supposed to give hormone replacement treatment, we can't, breast cancer or current or previous breast cancer is a contraindication. So you should take all these into account. So these are some basics which I am not going to address, because these things you do it in, usually you are supposed to do it in common practice. So we don't, as I said before, unless, if they are less than 45 years, and then you can do an FSH level. FSH level more than 30 indicates that they are menopausal. Okay, then you should, you can break the news, you can talk to them and counsel them. So you should know that, symptoms associated with menopause vary from people to people. Some people, they don't get any symptoms. Some patients come with severe symptoms and their threshold is very low. More than that, when they come to you, you should make sure that their contraceptive needs as well. Although they are menopausal, up to 1 year, or, if they come to you, you should also look at the menopause contraceptive needs, either a long-active reversible contraception or some form of contraception should be kind of discussed with them, because otherwise, we have had patients at the age of 48, 49, they are pregnant and they say, mage GP kiwa prashnayak naha baya wenna epa kiyala. So we get frequently we get these issues. So you have to make sure that they are using a contraceptive method until the age of 51 to 52. Or 1 year after menopause only, you can tell them you are safe. So if they menopause before 50 years, you should continue, for next 2 years. So these are the common, this is the overview of, women with perimenopausal age and menopause and symptoms. So let's look at, briefly what are the options for them. Now it's menopausal. When they come to you can advise, you should know the options. One is, we all know that hormone replacement treatment is one thing, yes, but I kept it as a third line. First line is, you as a primary health caregivers, you can talk about lifestyle modifications like regular exercises, weight reduction, and eating soya based food also is one of the dietary advice we give. Okay, so you should talk about lifestyle modifications, and then you can ask them to avoid, if they come with hot flashes, to have a shower and use fans and drink some cold water, and those are some of the remedies we advise. And there are non-hormonal therapies. So we'll discuss it again. We'll discuss it later. And hormones. So actually, a lot of the general practitioners, they are a bit, scared. Okay, hormones. Apita make a karanda ba. Apita make adala nae. So api kata karanda danne nae. So they don't. Most of them don't even talk about it. Make a haganda gihilla, doctor genkela. They refer to a physician or endocrinologist or a gynecologist. We'll clear that that now. So hormone replacement treatment is actually, in 90s there was a trial called Women Health Initiative trial that reported hormone replacement treatment with estrogen and progesterone increases breast cancer, increases cardiovascular disease, and venous thromboembolism. And that was published in papers, and all of a sudden people stopped hormone replacement treatment. However, subsequently it was reanalyzed, and then they found, okay, no, it is not so true, and it gives an insight into what hormone replacement is. And actually the final outcome was, final result was, the benefits outweighed the risks of continuing HRT. So the current ruling or current recommendation is, a healthy woman less than 60 years of age, or if a woman has reached menopause within 10 years, then the benefits outweigh the risks. Okay, so there is a good benefit. So they have a lot of symptom control. Basically, primarily hormone replacement treatment is given for two reasons. One is to reduce hot flashes. Secondly, urogenital symptoms. And secondary benefit is it reduces fractures. So if you know these things, that is enough. Hormone replacement treatment, if you give in the perimenopausal or menopausal age, it can reduce the symptoms significantly, hot flashes, and it gives a symptom relief. They get a huge benefit. Secondly, it reduces the urogenital symptoms like dryness in the vagina and dyspareunia, and that reduces whatever the urogenital symptoms, like even recurrent urinary tract infection. This is a treatment. So it benefits in terms of treating hot flashes, urogenital symptoms. And in the long run, if they use it continuously, there is a reduction in osteoporotic fractures. Those are the three main key things that hormone replacement treatment can do to women. However, life expectancy won't change. Okay, some women in England, I have seen when I was a trainee, some women, take hormone replacement treatment for more than 15 years. They believe that it reduces life expectancy. But however, it can be due to other things. They are doing a lot of exercise, their food habit is good, their lifestyle is good. But we evaluate them every year but they are doing it. They are taking it for many years and they think that maintains the youthfulness, but unfortunately, there is no evidence. Hormone replacement treatment increases small increased risk of breast cancer in the long run. If you continue for more than 10 years, if the woman has already some risk factors, combined hormone replacement treatment, estrogen with progesterone will increase the small risk of, there is a small risk of breast cancer. But this risk stops after stopping the hormone replacement treatment. So when a woman comes to you and tell, no, ahala tiyena doctor, breast cancer වෙනවලු නේද මං හරි බයයි. So you can educate them. That risk is small, that stops or after stopping the hormone replacement treatment. If you have a risk factor, if you are to get breast cancer in future, that will be advanced a little bit. That is the only finding, but that risk is also very low. So you can tell them when they, if they have doubt, you can talk, you can educate them. Hormone replacement treatment reduces endometrial cancer risk. It won't increase the cardiovascular disease, and it will not increase the muscle mass or strength. And also there is a myth. Women come to you asking for, sometimes they come to us asking for treatment for dementia. They think hormone replacement can reduce the dementia. It can be true, but we don't start hormone replacement primarily to reduce the dementia risk. In fact, research has shown if the hormone replacement is started after 65 years or more than that, it increases the dementia risk. So normally dementia, there is no place for HRT. We all know that, I have told you before also, hormone replacement treatment or giving hormones will reduce the fracture risk significantly. So if you continue for a longer time, the risk will be reduced. If you stop it early, and again the risk restarts. So these are the percentages. So in short, hormone replacement treatment can reduce osteoporotic fractures if they use it continuously or for a long time. So current guidelines now clearly say it does not increase the cardiovascular disease. Sri Lankan Menopausal Society says HRT should be started to control symptom relief. That symptoms are actually hot flashes, urogenital symptoms, not for cardiovascular, not to reduce dementia or any other things. So they can, it has to be started based on individual assessment. And if you annually, we should check, we should evaluate, or and up to 5 years this can be continued. But usually the rule of thumb is 1 to 2 years, but it can be continued for nearly 5 years. But there is no actual restriction also. If you evaluate properly, you can continue for more than 5 years as well. So if you happen to start hormone replacement treatment, you should always make sure this is a good practice. Apart from a good history, identifying the risk factors, identifying the contraindications, should always organize a mammogram or a breast scan, an ultrasound of the pelvis to exclude any other pathology, fasting blood sugar, lipid profile, or maybe you can do a vitamin D level, and also DEXA scan to assess the bone density. These are some of the good, the practices. Okay, so we'll talk about what is this hormone replacement treatment. It is similar to oral contraceptive pills. Okay, these pills have estrogen and progesterone combinations. Usually, this is the commonest one. Estrogen, there are two regimes. One is sequential estrogen and progesterone regime and continuous regime. This sequential is, it mimics periods. It mimics normal cycle. So it is usually given to women after 45 years and, just after menopausal. age. 50 to 51, we can use the sequential one because they can have periods and it's preferably mimicking the period is better. So we give sequential regimes. Commonly, in Sri Lanka, there is a brand called Femostone, 110 and 120. Femostone is the brand. It has estrogen and progesterone. First 14 days estrogen and second in combination. So they will have a period. So if a woman comes around 48 years with hot flashes, you can give this. You have to make sure that they don't have contraindications. If you are reluctant to give this, you can also give a low dose oral contraceptive pills to control their periods, as well as that gives a benefit in terms of hot flashes. But that estrogen dose is not enough. So if they have a severe hot flash, then you should go for this Femostone 110 or 120. Femostone or whatever. I'm just telling the brand because that is the only available brand in Sri Lanka, I think. Sequential regime, estrogen and progesterone. Estrogen, progesterone, because the reason why we don't give estrogen alone is when you give estrogen, endometrium become thickened and that will lead to hyperplasia and eventually endometrial cancer. So you should counteract with progesterone. When there is a uterus, you should always give estrogen and progesterone levels. Actually, and the progesterone is the culprit for breast cancer. So you have to be careful when you give estrogen and progesterone. Make sure that, do a mammogram, make sure that they don't have a family history of breast cancer, examine the breast and give estrogen and progesterone. Continuous therapy, combined therapy is, you give, that is a continuous one. There won't be any cyclical changes, so taken daily without any change in the estrogen and progesterone combination. This is given, combined therapy is given after one year of menopause. So the brand is called Femostone Conti. So continuous, we call it Conti or Conti, Femostone Conti. Femostone is the brand. So a lot of brands are there. So sequential and cyclical. Sequential is given to women who are perimenopausal or have just reached menopause, and it mimics menstrual cycle and regular monthly bleeds. So after 1 year, you can change into Conti or cyclical or combined ones, continuous one, sequential and continuous. This has estrogen and progesterone. And you give this to women who have uterus. If the woman had undergone a surgery and lost the uterus, then you give estrogen only therapy, because there is no need to counteract with progesterone. They need only estrogen. There are two brands, again, Femostone Mono, and there is a brand called Progynova. So 1 milligram or 2 milligram of estrogen should be given on daily basis. If they have there is another preparation called, again, Primarin or Clymen. We don't have that brand now. Estrogen, conjugated estrogen vaginal creams. It is applied to vagina to treat locally. If they come with urogenital symptoms, you can give that. Estrogen creams. And also you hear about, patients will come and ask about androgen patches. Androgen patches are actually meant to reduce or increase libido or minimize kind of libido related sexual disorders. This is given to women. Androgen increases libido. So, but however, it is not licensed for that practice, and it is only for, so far in Sri Lanka or any other countries, it is not widely practiced. And then you can give estrogen along with Mirena. Mirena is we call it intrauterine system. It releases progesterone into the uterus. So uterus need protection by progesterone. You can give oral estrogen and a Mirena insertion. So that is also one way. So let's have a look again. Estrogen and progesterone, sequential treatment and continuous therapy. Local estrogen creams are available. Oral estrogen only treatment is available for women without uterus. And estrogen can be combined with intrauterine system. So this knowledge is important. Even some gynecologists make mistakes. If you happen to see a patient with uterus and on estrogen only treatment, you have to educate and you should, organize something for them. Even unfortunately, you will see a lot of patients with all these bizarre treatment modalities. So your knowledge will help them to identify the problem and address the issue as well. So that's why I'm just telling you, you can also, as a GP, you can also start this. This is not a rocket science, or this is not a big magic. Okay. So, but make sure that they don't have contraindications. Breast cancer, any gynecological, breast, endometrial, or any hormone-dependent cancers, current or previous, is a contraindication. Undiagnosed vaginal bleeding, if they come with, if they think unscheduled bleeding, or, post-coital bleeding or irregular bleeding pattern, unless it is perimenopausal, if you do a scan, if everything is okay, then you can start. Because when they do a scan, when you get the scan report, you should look at the endometrium, see whether it is irregular, see whether they have documented any irregularity. Thickness, if the thickness is more than 15-20 millimeter, then it's prudent to do a biopsy. In postmenopausal woman, endometrial thickness should be less than 5 millimeter. Perimenopausal woman, actually there is no cutoff, but more than 15 to 20 is considered to be an unsafe thing. It's better to do a small biopsy. That biopsy is either hysteroscopic biopsy, or it can be a pipelle biopsy as an outpatient. We do it as well. Right. Okay. So undiagnosed vaginal bleeding and established cardiovascular disease, if they have a history of thrombovascular or thromboembolic disease, and any active liver disease, migraine with aura, these are some of the contraindications. But if the high blood pressure, if the hypertension is under control, that is not a contraindication. You can refer to this. There is a document published by the Menopausal Society of Sri Lanka. So this is clearly mentioned. These are the contraindications. So these are the hormones that we give to women in the perimenopausal or menopausal age. Okay, these are the only available things. Other vaginal rings and patches, estrogen patches, just forget about it. These are not available, and I don't think it will be available for next 10 to 15 years. So there are non-hormonal treatment options for hot flashes, actually. SSRIs, this paroxetine and gabapentin, clonidine, I don't know whether it is available, but fluoxetine and paroxetine, it works very well. If the woman has hot flashes, if the woman doesn't want to take hormone treatment, paroxetine 7.5 milligram daily or fluoxetine 20 milligram daily works very well. So I remember one of my relatives, she suffered a lot because of the hot flashes. She had diabetes and high blood pressure, so she didn't want to take hormone replacement treatment. So I started fluoxetine, and her husband came and thanked me. Doctor, ඔයා බෙහෙතක් දීලා හොඳට වැඩ කරනවා. හැම වෙලේම hina වෙලා ඉන්නේ. So irritability නැත්තෙම නැති වෙලා ගියා. And she's a happy woman. So husband came and thanked me. So you can try this as well. But this is not a hot flashes. This is not a well recommended treatment, but this can be done. This is this has some additional benefits as well. This increases the responses to pain. Their tolerance will increase. These are antidepressants also. So it's a multi-purpose one. So gabapentin, I don't know, I haven't used, but these are some of the evidence-based non-hormonal treatment options for vasomotor symptoms. And then this you should know about this. Actually, you should be able to advise on regular aerobic exercises, reducing alcohol and caffeine intake, weight management, smoking cessation, and mindfulness, yoga. These are the lifestyle modifications that they should do in order to reduce, minimize, or come out from this perimenopausal hot flashes and other symptoms. So what type of exercises? Any weight-bearing exercises, such as walking, jogging, and weightlifting. These things, weight-bearing exercises, and muscle-building exercises are also important. And swimming and cycling, these are some of the exercises you can suggest, or you can advise them. In your practice, you should you can have a perimenopausal health. What are the good practices and all? You can even have a poster, or you can develop. You can produce a YouTube clip or some health information leaflets. This we should empower women, and this should clear the myths, and they should work. Actually, they think අපි ගෙදර වැඩ කරනවානේ, ගෙදර වැඩ කරනවා. අපි හැම හදනවා, රිදි මරනවා. So, but in addition to that, they should do these activities as well in order to reduce the symptoms and improve the quality of life. So initially we looked at hormone replacement treatment, and I told you about non-hormonal evidence-based treatments, and then we talked about lifestyle changes, and again complementary therapies, and you can if they are going for that, you can't say no, but there are some complementary. They can go to acupuncture or whatever, non-evidence based methods, but people are still doing these things. And you should address the issue mostly when they come to you. Don't enforce your treatment options. Sometimes they may be only requesting you to give some vaginal lubricants or moisturizers. Okay, so listen to them. So ask what they exactly want, and and address the issue correctly. And you don't necessarily have to refer them to a gynecologist or an endocrinologist just because they come to you with some perimenopausal issues. You can address it at your level, and then you can consider referring to them. And actually, again, tailored approach based on the symptoms, as I said, medical history and patient's preference, and all this matter here. If you start some treatment, you should initially review at 3 months or 6 months, and then annually. And you should always involve the family, and you should explain to them the benefits versus the risks, and make them understand. And also in some women, now I recently met a girl. She reached menopause at the age of 25, actually premature menopause, and she was not on treatment for nearly 15 years, and recently she bled a little bit. So actually that should be treated as a postmenopausal bleeding. So I did a speculum examination, and I found that her vagina appeared pale in color, no rugae pattern. There were some red spots, and that indicated that she has atrophic vaginitis. So I counseled her, and I have started her on oral contraceptive pills because she doesn't have any symptoms other than that. She doesn't have occasional hot flashes. She's not worried about it. So she only wanted periods, and I have started common simple oral contraceptive pills and a little bit of estrogen cream vaginally, and she is now doing very well. So in addition to that, we also should consider giving calcium and vitamin D supplements, because our women lack vitamin D and calcium in our food. So maybe you should start calcium and vitamin D. That is a recommended practice. And also, so if they have persistent symptoms, then you can refer to a gynecologist. Apart from that, this is not only about perimenopausal and menopausal hormonal symptoms. They also can face lots of other conditions like abnormal uterine bleeding. Abnormal uterine bleeding in the sense they can have heavy menstrual period, they can have heavy irregular periods. It can be due to polyps in the uterine cavity. That can be due to hyperplasia of the endometrium. And initially a scan would clear a lot of things. If they have a little bit of irregularity, usually at general practice you can give a little bit of noethistone and a trial and see noethistone 5 milligram for 2 weeks, and to see whether that is because anovulatory bleeding will more estrogen. If the estrogen causes hyperplasia, endometrial thickness, or irregularity in the endometrium, little bit of progesterone will counteract that. or you can safely start a little bit of oral contraceptive pills to organize that as well as a first line treatment. But make sure that you do a scan and exclude other pathologies like, thickened endometrium or some polyps. Sometimes it can be a large fibroid, and do a speculum examination also to see whether sometimes some general practitioners have, unfortunately, they don't have speculum and they don't examine. So patients, a patient, one recently, a general practitioner was treating, and unfortunately there was a huge polyp sitting in the vagina. So when we do a speculum, my speculum didn't go in because there was a large polyp, and she needed a polypectomy. She by that time she had lost about 4-5 liters of blood. Actually, hemoglobin was 6 or 7. So likewise, you have to do a thorough examination before starting medical management for abnormal uterine bleeding cases at perimenopausal and menopause or any age. Make sure that they are fine. Even a transvaginal scan or abdominal scan would show something. And intermenstrual bleeding and intermenstrual, if they come with intermenstrual bleeding, if they come with postcoital bleeding, if they come with postmenopausal bleeding, these are red flag symptoms. You should always refer to a gynecologist to make sure that they don't have a cancer. Or if you have some experience, do a speculum, or organize a transvaginal scan to measure the endometrium, and maybe you can do a PIPEL also. These are some minor things. If you have facilities and if you have been trained to do so, you can do that. And often they come with urinary incontinence, like stress incontinence and urge incontinence. Stress incontinence, sometimes it can be a mixed incontinence as well. Stress, when they cough and sneeze, if they pass urine, that is stress incontinence. If they can't hold the urine, before they go to washroom, they leak and their frequency is high and they go frequently and they can't hold it, that is called urge incontinence. Sometimes this mixed pattern also exists. In that case, if it is, sometimes you have to, that needs a systematic approach. That can be initial lifestyle changes, there can be a prolapse, there can be urine infection, there can be a huge lump in the uterus or pelvis sitting there. So you have to exclude one by one. Urine incontinence is a bit tricky. So other than that, give me a second. Yeah. Then, and also commonest thing is they come with recurrent urinary tract infections. That is because of the lack of estrogen and less vascularity of the epithelium surrounding the vagina and urethra, and lack of elasticity, and that leads to that, because of that uroepithelium is prone to get infections. So the treatment is estrogen cream. Estrogen cream, we start as a, it is available as conjugated estrogen cream. Sometimes in the market it is not available. What I do is I tell them, if you have any friends going to India, bring it from India. So they bring few packs. So initially it comes with a canister. You apply it, one full canister into the vagina and lubricate it daily for 1 week. Then slowly reduce the dosage every other day for 1 week, and 3 times per week, and then twice per week, and maintenance once per week for up to 3 to 6 months would do. So if they feel again, they know what to do and they lubricate it. That's how we give estrogen. This local estrogen rejuvenates the vaginal tissue, that reduces the recurrent urinary infection, that improves the sexual quality of life, and that reduces the dyspareunia and vaginal discharge as well. Sometimes they come with severe itching in the vagina. You have to examine properly. If it is purely a candidiasis and lack of estrogen, then you can treat. If there is any patches, if there is any intense initial, even after initial treatment, if they have intense itching in the vaginal area, and if there is any whitish area or blackish patches, then you should refer to a gynecologist to take a biopsy and further treatment. So these are some of the practical issues that I discussed. Menopause is a natural phase of life requiring individualized care, and most women don't necessarily require laboratory tests to diagnose. treatment depends on patient to patient and tailor-made, and individually you can start, you can assess and start. And even at the primary level, you can, start hormones, non-hormonal treatment, and, initial risk assessment along with a little bit of some additional practical tests such as mammogram and lipid profile, uh, sugar levels, thyroid tests, and even a pelvic exam, pelvic ultrasound scan would give a lot of information. And it is a safe practice to do these things. And then you can start hormone replacement treatment. If you start it, you can continue it for 6 months to 1 year, and maintain up to 2 years. That would be fine. And more than that, if they require, maybe getting an additional help will be useful. Sometimes you can, if they have, when they are on hormone replacement treatment, if they bleed, that is called unscheduled bleeding. This unscheduled bleeding is a red flag symptom. You need to refer them. You need to look at it. So in summary, if the woman has uterus, combine estrogen and progesterone. If there is no uterus, only estrogen. Perimenopause or early menopause or menopausal less than 12 months age, sequential combined. The brand is Femostone 10, 110 and 120. So new brands will come. It is sequential one. If they menopause, they have reached menopause more than 12 months and no periods, continuous combined regime. That method is Femostone Conti is the one. And local symptoms, estrogen creams. Hot flashes, if they can't take hormones, then fluoxetine or paroxetine. And then again, finally, you assess them every 3 months or 6 months, and then annually. And you can even do, if you are scared, you can do an annual mammogram or ultrasound scan of the breast. These are the some of the practical tips that I can share with you. This is, I also don't know more than this actually. This is what I know. This is what I practice, and this is what my colleagues practice, and this is what I have gathered from going to conferences and reading books, and this is the standard for even for MRCOG or any at the level of exam also. This is the summary. Thank you. If you have any questions, we can discuss.
Thank you very much, Professor Rishard, for that informative session. You've actually empowered us with a lot of practical tips, and we truly appreciate that. We would now like to open the floor for any questions from the audience.
Hi, Dr. Rishard. Thank you so much. That was very, very useful. Can I just please ask you? You said we can use the topical estrogen cream, like for the patients with atrophic vaginitis and all of that. So when they're on that, are we supposed to do any other monitoring for them, or we can just do it for 6 months and stop?
Not really. You don't have to monitor. They only actually, even if a woman has had thromboembolism, this is only a local application, so you don't need to monitor. But make sure if the bleeding is, you have to make sure that it is coming. There is no postmenopausal bleeding. You should make sure that sometimes a pattern, they come and they don't tell, I had a spot. When you examine, you should know that it is not coming from the the endometrial or os. And also, if you do a scan will show endometrium, a thin endometrium. If the endometrium measures less than 4 millimeter, that means endometrium is atrophic and uterus is small. Then you are very confident. Then you can start. If they come with, usually if there is a cancer or something, they will have an unscheduled bleeding and fresh bleeding. Then scan will reveal it also. Usually ultrasound would always pick up an endometrial problem. So you can use it. Yeah, you don't need actually monitoring.
Thank you.
Thank you. We've got one more question from Fatima Shamla. Do we start invariably HRT in patients who have undergone total abdominal hysterectomy before 45 years, or do we start only if they have symptoms?
we have to start. We have to start it. Unfortunately, the problem is a lot of gynecology or units actually, when they do the hysterectomy, sometimes junior doctors, when they discharge, they don't address it. They don't tell it. Sometimes patients are also not at the level of listening to these things, and they go home and they will never come back. So make sure they should get, because it changes their quality of life significantly. We have had lots of important people. Some of them are actually teachers. Some of them are serving in big government facilities, and they are having severe symptoms of menopause. They have had hysterectomy with along with ovary, or without ovarian preservation, and they are not on estrogen treatment. So sometimes estrogen can be tricky in some patients, because if they have had endometriosis, estrogen will induce some endometrial growth. But there are brands like non-estrogen based. There is another hormone replacement treatment called Tibolone. That is, Tibolone is another type of hormone replacement. You can give it. So you have to make sure, or either refer them back to the unit, saying that could this patient be given safely given hormone replacement. It is actually a crime, because when you remove the ovaries, sometimes even hysterectomy alone, some doctors, when they do, sometimes ovarian vessels can be damaged because of the surgery. If that damage, they'll reach early menopause. They also need hormone replacement for actually to control their hot flashes, to improve the cardiovascular or the bone protection they need as well. And this needs to be educated in patients in the primary care setting. You should educate your patients regarding perimenopausal symptoms and menopause, and the availability of the options as well. Unfortunately, in Sri Lanka, it is lacking, and a lot of women, they think it leads to cancers and it leads to problem, and some of them think they will become dependent on this if they start it. So you have to motivate them. It is only for 6 to 12 months. In some maximum, it's for 2 years, and that will you should tell about the benefits more than that outweigh the risks.
Thank you so much. There's another question from Rashmira Balasurya. Do we have any vaginal moisturizers or lubricant brands available in Sri Lanka?
I can't remember now. Normally we give estrogen cream and Vaseline sometimes, but more than that I can't think of any. What I do is, if I have any doubts, I refer to, if they need anything further, I also get some opinion from dermatologist. We have had some patients with lichen sclerosis and lichen planus, so they come with itching. So we give estrogen and Vaseline. Time to time, we don't.
Thank
Yeah.
you. And there is another question. Sorry, go ahead. Yes, sorry. Go ahead. Sorry, go ahead. You were going to say something. Yeah.
Yeah. No, we use
Hello?
any
Hi.
simple. Yeah. Yeah. No. I finished. Evening primrose oil. Somebody has asked about use of evening primrose oil.
All right. So
Actually, evening primrose oil.
I hope it's okay that we can. Yeah. Yes. So that's right. Yes. Any benefits of using evening?
Yeah, evening primrose oil, actually, there is no direct benefit. It is not evidence based, but people give it to improve the breast pain. Actually, premenstrual symptom, it helps, and it improves breast related pains. Other than that, there is no place for hormone, kind of perimenopausal health. No menopausal health. No.
And
Fatty liver is not a contraindication also.
Yes, fatty liver is not a contraindication. Okay.
Sorry, can I also just ask one more thing? For a
Yeah.
patient who's sort of say on an IUD, say for contraceptive purposes, and sometimes they don't get periods at all, no, they become amenorrheic, right? So they put it in at the latter stage. At what point do we advise them to take it off? Like we won't know when they.
At
We won't know
51 years, 1
at
year
51.
after, 1 year after 51 or 50, 51, 1 year, 1 year or 2 years after.
Right. Okay. Thank you.
And I think in the interest of time, we'll take one more question. I think Fatima, Shamla, sorry, there was one more with Sahanaz. If we do a total abdominal hysterectomy and a BSO in a patient with endometriosis, how do we start HRT?
So we give, in some cases, we make sure that if there are no peritoneal deposits, we can safely start estrogen alone. But if that is controversial, so they can always go for tibolone. Tibolone is another one that doesn't have estrogen. So people who don't, who can't take estrogen preparations, tibolone is a type of hormone replacement treatment. So it is available in Sri Lanka, 2.5 milligram. You can give daily for maximum 5 to 10 years.
All right. And one final question from Shamla is, what is the role of AMH in diagnosing premature ovarian menopause? And if a woman on HRT needs contraception, how to prescribe COCP when they are already on HRT?
Actually,
this is our last
HRT,
question.
yeah. COCP, actually, we don't normally, we don't give either if you give COCP, now HRT, when they are having hormone replacement treatment, they are already menopause. So we don't normally, it's a tricky question, but you don't have to. They have reached menopause, no? That's why we are giving HRT. So you don't have to give. And AMH levels is actually, it gives an arbitrary value, or it gives a value, or it tells about the ovarian reserve only. It does not talk about menopause. Menopausal status, we look at the FSH level. So invariably, they will also have a low AMH levels as well. So AMH, sometimes we have patients with premature menopause, and AMH is, if the AMH is good, we can stimulate and get some eggs and do IVF. So that's where that's the place we do AMH, to see whether they have some reserve at least to prepare.
All right. Thank you. Thank you so much. I think we'll end the session here. So on behalf of the President and the Council of the College of General Practitioners of Sri Lanka, I would like to extend our heartfelt thanks to Professor Rishard for joining us this evening and for delivering such an insightful and engaging presentation. It was truly, thank you very much. You took a lot of time to explain a lot of things to us and empowered us with a lot of practical tips. So thank you so much. I would also like to express our sincere appreciation to all of you in the audience for your active participation and continued support. We look forward to welcoming you again at our next CME webinar session in September. Until then, stay safe and have a pleasant evening.
Thank you. Thank you very much for inviting me. I really enjoyed doing this lecture.